The next lecture is Lipid, COVID and Cardiovascular Disease in Others. Speaker is Dr. Arnab Datta. Please.
Thank you, sir. It's my pleasure and honor to be talking in front of all my senior teachers, colleagues, and hi to my junior friends also. I will be focusing on trials that have influenced our practice with respect to three other important aspects of cardiology and cardiovascular science. The one is completely new for the last 1.5 years, that is COVID and cardiovascular disease. The trials that we have had that have been published in the last 12 months on the management of the cardiovascular aspects of COVID, which have influenced our practice, and some new data that we have on dyslipidemia and hypertension. I don't have much time, and hence I will only summarize those aspects in 2 or 3 slides. Coming to COVID and cardiovascular disease, the most important trial in the last 1 year to have influenced our practice is this trial known as the ACTION trial. This was about anticoagulation in patients hospitalized with COVID-19. We know that cardiovascular manifestations of COVID have been common apart from respiratory complications. We have been using thromboprophylaxis, both oral and parenteral, in various doses and various molecules. But what does the evidence base have to say about anticoagulation in hospitalized patients and thromboprophylaxis for COVID-19 patients? So this was the background on which this study was done. Very important to remember that elevated biomarkers of thrombosis such as D-dimer, etc., are associated with disease progression and higher mortality. That has already been shown by trials by Gungor et al., showing that elevated thrombotic biomarkers are associated with worsening outcomes. And also recent data had suggested that anticoagulation might improve clinical outcomes. But it was not clear that which patients, what is the type of anticoagulant, what is the correct dose and duration for these drugs was completely unknown. And this ACTION trial was designed to assess whether a strategy of therapeutic anticoagulation primary with rivaroxaban was effective in preventing complications in patients hospitalized with COVID-19 with elevated D-dimer levels. And that is why a randomized trial was comparing both the efficacy and safety of this design was seen in the randomized mode. This was the trial design, and which has been since published in the American Heart Journal this year. It included adult patients. Important to remember that all of them had elevated D-dimer more than the upper limit of normal at admission. The patients were randomized, about 615 patients were randomized, and stable patients in hospital were given rivaroxaban with a full dose of 20 milligram, and unstable patients in the in-hospital stay were given enoxaparin in a dose of 1 milligram per kg twice a day, and that was followed up by rivaroxaban for the next 30 days. This was the study flow diagram, again, which showed that about 300 patients were allocated in each arm, and they were then sent for primary analysis. And you can see here that there was no significant difference between prophylactic anticoagulation indicated on the basis of hospitalized patients and their risk of thrombosis and routine therapeutic anticoagulation, either with rivaroxaban or enoxaparin, was not found to be different. So, in hospitalized patients with D-dimer levels, elevated D-dimer levels, initial in-hospital therapeutic anticoagulation followed by short-term rivaroxaban therapy, did not improve clinical outcomes and rather increased bleeding compared with in-hospital prophylactic anticoagulation. So what is the summary of recommendations as far as thromboprophylaxis in COVID-19 disease for cardiovascular risk reduction is concerned? That patients on chronic anticoagulation or antiplatelet therapy should continue their current regimens despite COVID-19 diagnosis. But again, hospitalized patients, routine thromboprophylaxis for outpatients with mild COVID-19 is strictly not recommended. Hospitalized patients should only receive pharmacological prophylaxis with either low molecular weight heparin or alternatively unfractionated heparin, depending on the renal profile, with standard prophylactic doses. No role of therapeutic anticoagulation, either with NOACs or routinely with low molecular weight heparin, is no longer recommended, even in patients with elevated biomarkers of thrombosis, including D-dimer. Also, post-discharge prophylaxis must only be considered based on bleeding and thrombotic risk per se, and not as standard guidelines for all patients. And patients with venous thromboembolism are the only set of patients who should be treated with therapeutic doses of anticoagulation, and the choice of agent in that case should be guided by patient-specific factors like renal function, like body weight, etc. The second important trial that I need to summarize in COVID cardiovascular interaction is the role of statins. And unfortunately, this study known as the Inspiration and the Inspiration S trials have also proven to be negative trials, which were actually open label randomized trials where initial randomization was between standard dose anticoagulation and a second randomization was with statin therapy. And there again, you can see that double-blind assignment to atorvastatin 20 milligram once daily versus placebo was done. And this again was approximately a 10-month trial starting in July 2020, and enrollment was stopped in April 2021. And now that we have the data, again, you can see the first randomization between standard dose enoxaparin and intermediate dose enoxaparin, the hazard ratio is only 1.06%, and the p-value 0.61 is not significant. So also, the second randomization of atorvastatin versus placebo, again, there was no difference in the primary outcome of all-cause mortality or ischemic stroke, and hence it was seen that in patients with COVID-19 admitted to ICU, statin in a standard dose of 20 milligram did not result in significantly reduced risk of primary outcome, ECMO, or all-cause mortality. So the conclusion was that in sick patients admitted in ICU with COVID-19, statin therapy did not result in any significant reduction of risk of primary outcome, including thrombosis, treatment with ECMO, or all-cause mortality. These are the two important negative trials which have influenced our cardiology practice as far as COVID complications is concerned. One was the ACTION trial and the other was the INSPIRATION trial. And unfortunately, both of these trials have turned out to be negative. Regarding lipids, Dr. Hajra in his earlier lecture, in the first lecture of this session, has already talked in details about the newer targets that are coming up regarding LDL cholesterol reduction, because we now have a lot of newer agents in dyslipidemia, apart from statins, apart from ezetimibe, and apart from PCSK9 inhibitors, which are now being approved and under review and also in early clinical development as far as new targets for LDL cholesterol reduction is concerned. Bempedoic acid, again, is this is a phase 3 program, and it has been launched with the trade name of Nexletol, both in United States and the European Union. And there are a lot of trials being designed and which are being already going on as we talk, which are known as the CLEAR group of trials. These are the CLEAR Harmony, CLEAR Wisdom, CLEAR Serenity, Tranquility, and Outcomes trials. And these will all look at this new drug of bempedoic acid along with a fixed dose combination of with ezetimibe. And they will all be used in adults with heterogeneous familial hypercholesterolemia or established atherosclerotic cardiovascular disease who require additional cardiovascular morbidity and mortality reduction by LDL cholesterol lowering. Apart from this bempedoic acid, the other genetic technologies which are in the horizon are the monoclonal antibodies, the antisense oligonucleotides, the siRNA, which are all being developed. Particularly in these group of new drugs, 2 drugs are important which need to be highlighted in 2021. One is evinacumab, which has been approved by FDA as an adjunct to other LDL cholesterol lowering therapies, particularly in homozygous familial hypercholesterolemia. And it is actually an inhibitor of the enzyme lipoprotein lipase. The change of LDL cholesterol is very, very significant with evinacumab, and the p-value in all the regimens, the dosage regimens, are highly significant. The other molecule that I was talking about is inclisiran, and that is actually siRNA which targets the PCSK9 receptor, and that is the mechanism of action. Again, a lot of trials are already in the horizon which are investigating inclisiran use to support LDL cholesterol lowering, and they are as a whole known as the Orion group of trials, the Orion 9 trial, the Orion 10 trial, and the Orion 11 trial, of which the Orion 10 trial is the most important, where it is looking at the use of inclisiran in atherosclerotic cardiovascular disease patients who have persistent higher LDL cholesterol more than 70 in spite of maximally tolerated doses of statin and ezetimibe. So, to summarize what is going on in the arena of lipid management, and in 2021, the trials have all been targeting the non-statin LDL cholesterol lowering therapy regimen, which provides additional options for management of patients with increased residual atherosclerotic cardiovascular disease risk, of which I have said the 3 important molecules which are there very much in the phase 2 and phase 3 trials. One is the bempedoic acid, along with ezetimibe, which has lesser muscle side effects and cardiovascular outcome data is pending. Then we have the evinacumab, which I said is actually a monoclonal antibody targeting lipoprotein lipase, and that has been approved for the treatment of homozygous familial hypercholesterolemia. And lastly, we have inclisiran, which is actually an injectable siRNA which inhibits PCSK9 translation and can be given at a 6-monthly dosage. So agents are under development targeting the various newer proteins and enzymes through siRNA and antisense technology, which may offer further LDL cholesterol lowering and may optimize further lipid management in the near future. The last aspect of cardiovascular disease in 2021, which I thought needs to be highlighted in a podium, in a forum like this, where we are discussing new things, things which are on the horizon, which have been which have come in 2021, which we all need to know and share with each other, is the Radiance HTL trial. This is a completely new sham-controlled renal denervation trial. We know that after Simplicity 3, the enthusiasm for renal denervation had gone out quite a lot. But now, with sham-controlled, more properly designed and properly included patients in trials for renal denervation, we might now see a resurgence of renal denervation in the future. Particularly, this trial may be the harbinger of this new era for renal denervation, which is known as the Radiance HTN trial. So, endovascular renal denervation, we know that it reduces blood pressure, but its blood pressure lowering effect has not been previously demonstrated in patients with resistant hypertension. So this trial was done with the study objective to investigate whether endovascular ultrasound renal denervation reduces daytime ABPM in patients who were hypertensive and resistant to a standardized fixed dose triple medication pill. So what is this actually? It is known as the Paradise ultrasound renal denervation system. It's a completely designed system which comes with its own console. A ring of ablative energy is given to interrupt the renal traffic, renal nerve traffic, and the arterial wall is protected by the water circulating through the balloon. Yes, I'll just summarize in 1 or 2 more slides. So 2 to 3 sonications are given lasting 7 seconds. This was the trial design. You can see that it was a sham-controlled trial where ultrasound renal denervation was completely randomized with a sham procedure. The office BP was more than 140/90, even with 3 or more hypertensive medications. All the patients did have a renal angiogram. About 1,000 patients were enrolled and only 136 underwent randomization. Around 70 patients underwent renal denervation, but you can see here that the daytime ambulatory blood pressure reduction was significant in the renal denervation arm compared to the sham. You can see here the p-value was significant both in the ITT population as well as the complete ABPM population. There was significant blood pressure reduction up to 6 to 9 millimeter of mercury in the renal denervation arm. Also, additional follow-up will be required to determine whether blood pressure lowering effect is safe and durable over time, and most importantly, whether these patients who remained uncontrolled would have been helped with additional antihypertensive agents, particularly spironolactone. Also, pre-procedural predictors of responsiveness, and there are no intra-procedural markers whether actually successful denervation has been done or not. Since that cannot be done, patient variability will continue to be observed in such a observer-dependent and operator-dependent procedure compared to a randomization. So, in patients with hypertension resistant to guideline-recommended triple drug therapy, ultrasound RDN may be effective in further reduction of ABPM, but again, longer-term assessments for efficacy as well as safety are required and are already ongoing. And we need to look at renal denervation in a newer light in 2021 and look at more trials to more effectively manage resistant hypertension in the future with something more than what pills offered till now. Thank you very much, everybody, for being a part of this discussion.
Thank you, Dr. Arnab.